Hello, I'm Dr. Brad Black, and we are here at the VERION reference unit where we are getting ready to plan a surgical procedure to be done here in a short while. Our patient has already had their axial length measured with a lens star, and we have imported that data on a USB stick to the reference unit here. We've already taken an image of their eye, a high definition image that will register not only conjunctival vessels but iris structures as well. That information has all been transferred to the screen here where we will begin our planning. Today we are going to operate on this patient's left eye, and their goal is to obtain the best distance vision they can. So the first things that we look at here would be their refraction, which shows a diopter and a quarter of astigmatism, and we also look at their corneal curvature, which here shows almost 2 diopters of corneal curvature and an oblique axis of 46. So what we would like to do then is determine what is the best course of action to give this patient the best possible distance vision. Interestingly enough, I personally feel that as the more of the astigmatism correction we can get in the lenticular plane, the better we are. However, this allows us to look at all different modalities. For instance, we can slide this bar over here to do purely AKs. And if we do that, because it's an oblique axis, it turns out the AK interferes with our incision here. And so if we were to do this, we would have to move our incision. However, if we as we slide the bar over to the left to get more and more implant power here, we see that the AKs become very small. And if we go all the way over to a 100% IOL correction, we can then look down here and see that if we use a T5 lens, we are going to have a residual of 0.03 diopters, which is really quite good. Now that takes into consideration our surgically induced astigmatism and at the axis of our incision, which for a left eye, I use at 15 degrees since I'm a right-handed surgeon. You can see we do not have a side port. I do a one-hand pre-chop technique. So for this particular patient, we have a power of 14.5 diopter with a T5 lens that is going to leave us a residual of 0.03 diopters of cylinder at the axis of 46. So our anticipation here is this patient will do very well with a toric lens. Interestingly enough, we take readings in both eyes, and while we are planning a surgery in the right eye, probably in a week or so, depending on the patient's request and desires, I would tend to go ahead and make my plan for the opposite eye as well, just as an efficiency type thing. So if we look over here at the right eye, we see there's much less refractive cylinder, and yes, I do look at the refractive cylinder as well as the corneal cylinder. There's only 3/4 of a diopter refractive cylinder at 62 degrees. When we look at the corneal astigmatism, it's less than a half a diopter at 124. So my plan here would be to try to do a toric lens if at all possible. Again, I like to correct astigmatism at the lenticular plane versus the corneal plane if at all possible. But as we can see here, if we go over to 100% IOL, we still have a WF lens that's called for. There is just not enough cylinder here, even if we look at surgically induced astigmatism. So I like then to go back to 100% AK correction. Again, we do not have a side port. We see now that if we do paired arcuate incisions at this axis, we would then be able to eliminate virtually all of the cylinder, and using a 12 diopter, this is a high myope, we could then eliminate the astigmatism using 16-degree arcs, and I like to use an 80% depth. Interestingly, if you like a 90% depth, you can enter 90% in here, and it will change the length of your incision. As we know, you get more effect with a deeper incision. So my general philosophy is I like to correct the astigmatism in both eyes the same. However, there are instances where it is so obvious that one eye needs a toric lens. I will use toric in one eye and arcuate incisions in the opposite eye, as you see here. We do use the Holiday 2 formula, but various formulas are available with this planner. This planner has made us much more efficient in the office as well as in the operating room. So all of this information will then be collected on the USB stick, and we can then take that down to the DML and plug it in and have all this information entered right into the LensX laser. The AKs are placed where they're supposed to be, the arcs, and then the axis would also be placed. We do not have to mark the limbus anymore intraoperatively. We then take that USB port following the femto procedure and use it in the operating room with our Luxor microscope and the Centurion. We are able to get an overlay that shows us exactly where the lens is to be oriented and the intended axis of 46 degrees. Again, with no marks, just using the registration that we've gotten from our high definition image at this reference unit. All in all, this has just been a phenomenal addition to our armamentarium here. I think it's a wonderful technology that improves our efficiency. So thank you for your attention.